Welcome. Today we take on cirrhosis, not the textbook version. The version that arrives at 2 in the morning. We will follow one patient from the emergency department door to the discharge summary. Along the way we build the framework, what cirrhosis actually is, how it is staged, and the 3 complications that define the word decompensated. Variceal bleeding, hepatic encephalopathy, and hepatorenal syndrome. By the end you should be able to score a patient, estimate their next year, and know the first moves for each of those complications. Meet Dale. He is 54 and drives long haul. His sister brought him in for 2 days of black tarry stools, and for 3 days of not being himself, sleeping all day, losing words. His blood pressure is 96/58. His heart rate is 104, and she mentions that he stopped his lactulose 2 weeks ago because it made him go too much. Hold on to that detail. Before we teach a single fact about cirrhosis, ask yourself which complications are already in this room. Here is the plan. First, we define cirrhosis and what decompensated really means. Second, we walk the physical exam. 2 separate families of findings: liver failure and portal hypertension. Third, we read the laboratory studies, including 2 results that mislead almost everyone. Fourth, we stage risk with the Child-Turcotte-Pugh score and with the model for end-stage liver disease score, or MELD. And fifth, we manage the 3 decompensating events: variceal bleeding, hepatic encephalopathy, and hepatorenal syndrome. All of it through Dale. Back to the history. Themelena started 2 days ago. Black, tarry, foul. The confusion started 3 days ago and is worse at night. His abdomen has been swelling for 3 weeks, and he stopped his lactulose 2 weeks ago. Now notice what is missing. No fever, no abdominal pain. That matters, because in a patient with cirrhosis, a bleed and an infection are the 2 things most likely to tip the brain over. See how much of the diagnosis is already sitting in the history. Now the background. He was diagnosed with hepatitis C 12 years ago and never treated it. He has been drinking about a pint of vodka a day for 20 years. He takes ibuprofen for his back. He takes his diuretics when he remembers. And he has never had an endoscopy. Every one of those lines comes back later in this case. The hepatitis and the alcohol explain the cirrhosis. The ibuprofen and the diuretics threaten his kidneys. And the missing endoscopy means nobody ever looked for varices. The exam sorts into 2 families. The first is liver failure. Jaundice shows once the bilirubin passes about 2.5. Spider angiomata and palmar erythema follow a rise in estradiol. Then look at the hands. Tarry nails, Merkel-lines, Dupuytren contractures, then gynecomastia, enlarged parotid glands, testicular atrophy, and asterixis. The second family is portal hypertension, a large spleen, ascites, dilated abdominal wall veins called caput medusae, and an epigastric venous hum through a recanalized umbilical vein. Dale has findings in both columns. So what is cirrhosis? Follow the 4 steps. Step 1. Chronic injury of any cause. Step 2. The liver responds with fibrosis and regenerative nodules. Step 3. That scar and those nodules distort the hepatic vascular architecture. Blood can no longer flow through easily. Step 4. Portal pressure rises. That last box is the one to remember. Almost everything we discussed today, the varices, the encephalopathy, the kidney failure, flows downstream from elevated portal pressure. Decompensated is not a vague word. It means a complication of raised portal pressure has appeared. There are 3. A variceal bleed, ascites, or hepatic encephalopathy. Ascites is usually the first to arrive, and it gets its own lesson. Today we follow the other 2, plus the kidney failure that trails behind them. And 1 number for the definition. Portal hypertension means a hepatic venous pressure gradient above 5 mm of mercury. Dale walked in with 2 of the 3 at once. Where does cirrhosis come from? 4 causes account for most of what you will see. Alcohol and other toxins, such as arsenic. Metabolic dysfunction-associated steatotic liver disease, known as MELD, which explains most of what used to be called cryptogenic cirrhosis. Chronic viral hepatitis, B, C, and D, and autoimmune hepatitis. Classically a woman with a high immunoglobulin G and positive anti-nuclear and anti-smooth muscle antibodies. Dale carries 2 of these 4. Now 4 categories you have to ask about before anyone calls a cirrhosis cryptogenic. Metabolic disease, hemochromatosis, Wilson disease, alpha-1 antitrypsin deficiency, biliary disease, primary biliary cholangitis, and primary sclerosing cholangitis. Vascular disease, Budd-Chiari syndrome, right-sided heart failure, constrictive pericarditis. And medications: amiodarone, methotrexate, vitamin A, valproic acid, and isoniazid. A drug history is part of a liver workup. Now the laboratory studies. The bilirubin rises, the international normalized ratio rises, and the albumin falls. Both of those measure synthetic function. The aminotransferases are variable, and late in the disease the aspartate aminotransferase runs higher than the alanine aminotransferase. The alkaline phosphatase moves around and is less useful. Look at Dale on the right. Bilirubin 4.8, albumin 2.6, international normalized ratio 1.9. His synthetic function is failing. Here is the first trap. A high international normalized ratio in cirrhosis is not a bleeding time. It correlates poorly with actual bleeding risk. The reason is elegant. Factor VIII is normal in these patients because the liver does not make it, and the natural anticoagulant proteins fall right alongside the clotting factors. So the system rebalances at a lower level. The practical point: do not transfuse plasma to chase a number. Treat the patient in front of you. The rest of the panel tells its own story. Anemia from marrow suppression, hypersplenism, and iron or folate deficiency, neutropenia and thrombocytopenia, mostly hypersplenism, with low thrombopoietin and direct alcohol toxicity adding to the low platelets. The sodium falls because antidiuretic hormone rises in response to a low effective arterial volume. And do not overread the iron studies. A high ferritin and a high transferrin saturation, that is serum iron divided by total iron binding capacity, usually just mean iron spilling out of injured hepatocytes. The binding capacity itself is typically normal or low here. The workup runs in 4 moves. First, an abdominal ultrasound with Doppler, liver size and echo texture, ascites, vessel patency, and a look for cancer. Second, find the cause, hepatitis serologies, autoimmune studies, iron and copper studies, alpha-1 antitrypsin, antimitochondrial antibody, and tissue transglutaminase. Third, stage the fibrosis without a needle. An aspartate aminotransferase to platelet ratio above 2 is a useful clue, and elastography measures liver stiffness. Fourth, biopsy remains the gold standard, but is not always needed. Now we stage the risk. The modified Child-Turcotte-Pugh score uses 5 inputs. 3 are laboratory values: bilirubin, albumin, and the international normalized ratio. 2 come from your own examination: the amount of ascites and the grade of encephalopathy. That is worth pausing on. 2 of the 5 variables in the most used prognostic score in hepatology are decided at the bedside, so examine carefully. Your grading moves the class, and here is why the score matters. Class A is 5 to 6 points. 1-year survival about 100%. Class B is 7 to 9 points. 1-year survival about 80%. Class C is 10 to 15 points. 1-year survival about 45%. Read that bottom row again. A patient in Class C has roughly a 1 in 2 chance of dying within the year. That is the number that should change how urgently you refer, and how you talk to the family. The second score is MELD, the model for end-stage liver disease. The sodium version uses 4 inputs: total bilirubin, the international normalized ratio, creatinine, and sodium. The newer 3.0 version adds 2 more: sex and albumin. Either version predicts 3 months survival, and it drives the transplant waiting list. One caveat: when the MELD is under 21, it can understate risk. Refractory ascites, a high hepatic venous pressure gradient, and poor quality of life all add information. Let us score him. Bilirubin 4.8, 3 points. Albumin 2.6, 3 points. International normalized ratio 1.9, 2 points. Moderate ascites, 3 points. Grade 2 encephalopathy, 2 points. 13 points in total. That is Class C, which puts his 1-year survival near 45%. His MELD lands in the high 20s. Now hold that in your head as we walk through the complications, because everything that follows is happening to a Class C liver. Now the first complication. The reason Dale is passing black stool: when portal pressure rises, the blood looks for another route back to the heart. It finds thin-walled collateral veins in the wall of the esophagus and the stomach. Those are varices. They are not a disease of the esophagus. They are a pressure problem showing up in the wrong place. Let us look at who has them, who bleeds from them, and what we do before and after that first bleed. How common are varices? That depends entirely on how sick the liver is. In child Class A patients, about 40% have varices. In child Class C, about 85% do. So the presence of varices tracks the severity of the liver disease, which means the class you calculated a moment ago is already a rough prediction of what the endoscopist will find. Dale is Class C. The odds were always high, and nobody had ever looked. Having varices is not the same as bleeding from them. 3 features raise the risk: larger varix size, child Class B or C, and red whale marks. Those are the red streaks the endoscopist describes running along the surface of the varix. That is why the recommendation is to screen with endoscopy at the time cirrhosis is diagnosed, and the prevention data are strongest in patients with medium to large varices. Dale should have had that endoscopy 12 years ago. First option for primary prevention: a non-selective beta blocker. In patients with medium to large varices, these cut the risk of bleeding by roughly 50% and lower mortality. Carvedilol is preferred over nadolol or propranolol because it lowers both the mean arterial pressure and the hepatic venous pressure gradient more, and it delays progression of the varices. Titrate to the maximum tolerated dose. Keep the systolic pressure at or above 90, and you do not need a repeat endoscopy to prove that it is working. Second option: endoscopic variceal ligation. Banding. Compared with a beta blocker, it is better at preventing that first bleed. But there is no difference in mortality, and it carries real risks: esophageal perforation and post-banding ulcers. It is also a program, not a single procedure. You repeat banding every 1 to 4 weeks until the varices are gone. Then a follow-up endoscopy at 3 months, and then every 6 to 12 months. So which do you choose? Honestly, the guidance leaves room. For small varices, a beta blocker is often the first move. Larger varices may benefit more from banding. And here is the part people get wrong. Combining a beta blocker with banding is not recommended for primary prevention. Beyond that, the choice comes down to patient and physician preference. Can this patient tolerate a beta blocker? Will this patient come back every few weeks for banding sessions? Now change the situation. Your patient has already bled once. Everything becomes more urgent. Roughly half of them will bleed again, and the mortality associated with that first bleed is about 30%. Those two numbers are the reason nobody leaves the hospital after a variceal bleed on nothing. The first bleed converts a screening conversation into a treatment obligation. Dale is now on that side of the line. Before we get to prevention, one thing belongs in the acute phase, and it is the step residents forget. Every patient with cirrhosis and gastrointestinal bleeding gets antibiotic prophylaxis, ceftriaxone, 1 gram intravenously daily for 5 days. Started at presentation, not after the cultures return. Bacteria translocate out of the gut while these patients bleed, and infection drives both rebleeding and death. Prophylaxis lowers infection, lowers rebleeding, and lowers mortality. Dale got his first dose in the emergency department. So what is secondary prevention? For every patient after a first bleed, a non-selective beta blocker plus a banding program. The combination beats either one alone. That is the opposite of the primary prevention rule. If bleeding is refractory, a transjugular intrahepatic portosystemic shunt is the next step. And in child class B or C, an early shunt within 72 hours of admission can be considered. It reduces rebleeding, it increases encephalopathy, and it does not change mortality. Now the second complication, the one that actually frightened his sister: hepatic encephalopathy. Residents often treat this as a lactulose problem. It is not, it is a detective problem. The lactulose is the easy part. Working out why the brain failed today is the part that changes the outcome. So let us build the mechanism first, then the list of precipitants, then the treatment. Follow the mechanism in 4 steps. Step 1. The failing liver cannot detoxify ammonia and a set of other substances. Asymmetric dimethylarginine is one of them. Step 2. Those substances drive cerebral edema. Step 3. Brain oxygen consumption falls while reactive oxygen species rise. Step 4. The result is global brain dysfunction. Notice that ammonia is part of the story, but it is not the whole story, which is exactly why the blood ammonia level performs so poorly as a test. Here is the list to run every single time. Bleeding, especially into the gut. Infection. Look hard for one. Medication non-adherence, which is Dale. Low potassium and low sodium. Volume depletion. Hypoxia. A portosystemic shunt. Sedating medications. And any acute insult to the liver, such as a portal vein thrombosis. Dale has 2 of these at once. He stopped his lactulose, and he is bleeding into his gut. Correct those, and the brain usually follows. Here is the second trap. Hepatic encephalopathy is a clinical diagnosis. The history, the examination, the asterixis, that is what makes the call. Serum ammonia levels have poor sensitivity for making the diagnosis, and they are just as poor for monitoring the response to treatment. So do not order daily ammonia levels to decide whether your patient is improving. Watch the patient. And before you settle on this diagnosis, make sure you have excluded the other reasons a sick patient becomes confused. Treatment starts with the precipitant. Stop the bleed. Treat the infection. Replace the potassium. Then, lactulose. It acidifies the colon so that ammonia is converted to ammonium. Ammonium is charged, so it stays in the gut and leaves with the stool. The dose is titrated to effect, and the goal is 2 to 4 stools a day, not 10. Overshooting causes dehydration, which precipitates the very encephalopathy you are trying to treat. Polyethylene glycol is also effective. When lactulose is not enough, add rifaximin, 550 mg twice a day. It reduces the gut bacteria that produce ammonia. Add it if the patient is refractory, after a second recurrence on lactulose, or after a shunt procedure. Then, 2 quiet supportive rules. Keep the potassium above 4, and avoid alkalosis where you can. Both of those states push more ammonia toward the brain. Rarely we reach 4-branched chain amino acids, L-ornithine L-aspartate, or probiotics. The third complication is hepatorenal syndrome, and the mechanism explains the treatment. Follow it across. 3 systems fire at once: the sympathetic nervous system, the renin-angiotensin-aldosterone system, and vasopressin. They constrict the renal vessels, renal blood flow falls, and the creatinine climbs. But look at that last box. The kidney itself is not damaged. It is starved. Now read the precipitants along the bottom. Gastrointestinal bleeding, overdiuresis, infection, repeated large volume taps, aminoglycosides, and nonsteroidal anti-inflammatory drugs. Dale has hit 3 of them. The diagnosis is made by subtraction. 6 criteria. 1. Cirrhosis with ascites. 2. Acute kidney injury. A creatinine rise of at least 0.3 mg per deciliter within 48 hours, or a rise of at least 50% above baseline. 3. No improvement after you stop the diuretics and give albumin at 1 gram per kilogram per day for 2 days. 4. No shock. 5. No nephrotoxic medications. 6. No intrinsic kidney disease. You have to earn this diagnosis. There are 2 forms. Hepatorenal syndrome with acute kidney injury develops in under 2 weeks. It usually occurs in severe liver failure, often right after a precipitating event, and the median survival is about 2 weeks. Read that again. 2 weeks. The chronic kidney disease form is more indolent. The degree of liver failure is less, and median survival is about 6 months. The acute form is the emergency, and it is the one Dale is heading toward. Treatment splits on how sick the patient is. If they are a critically ill, start terlipressin, or another vasopressor, such as norepinephrine or vasopressin, together with albumin. The target is a mean arterial pressure, 10 mm of mercury, above where you started. If they are not critically ill, use octreotide, 100 to 200 micrograms under the skin, 3 times a day, plus midodrine, up to 15 mg by mouth, 3 times a day, plus albumin, 1 gram per kilogram on the day of presentation, maximum 100 grams, then 20 to 60 grams daily. If that fails, dialysis or a shunt can bridge to transplant. Day 4. The bleeding has stopped. The confusion is better, and his creatinine has climbed from 0.9 to 2.4. So walk the criteria. He has cirrhosis with ascites. He has acute kidney injury. The diuretics were held and he had 2 days of albumin with no improvement. He is not in shock. His urine sediment is bland, and the ibuprofen was stopped on arrival. That is hepatorenal syndrome. The acute kidney injury form. He is not critically ill, so he starts midodrine, octreotide, and albumin. Put it all together. Dale has decompensated cirrhosis from 2 hits, 20 years of alcohol, and 12 years of untreated hepatitis C. He is child class C at 13 points. He bled from esophageal varices. He was banded and covered with 5 days of ceftriaxone. His banding program continues, but his beta blocker is on hold while he is in hepatorenal syndrome and hypotensive. It restarts once his kidney function and his blood pressure recover. His encephalopathy came from stopping lactulose and from the bleed. Lactulose is restarted and rifaximin added. His kidneys are on albumin and vasoconstrictors. And 3 things must change: the ibuprofen, the alcohol, and his untreated hepatitis C. 6 things to carry with you. The international normalized ratio is not a bleeding time. An ammonia level neither makes nor follows the diagnosis of encephalopathy. Non-steroidal anti-inflammatory drugs have no place in cirrhosis. Every new diagnosis of cirrhosis earns a screening endoscopy. A beta blocker plus banding is the rule after a bleed, but not before one. And hepatorenal syndrome is only yours to diagnose once you have excluded shock, nephrotoxins, and intrinsic kidney disease. Let us close. Cirrhosis is fibrosis and regenerative nodules distorting the vasculature and raising portal pressure. Decompensation means variceal bleed. Ascites, or encephalopathy. The Child-Turcotte-Pugh class is the number that predicts the year, and class C sits near 45%. After a first variceal bleed, every patient gets a beta blocker and a banding program. In encephalopathy, hunt the precipitant before you blame the ammonia, And hepatorenal syndrome is diagnosed by exclusion and treated with albumin and vasoconstrictors. These are the guidelines and the studies behind what we covered. The practice guidance documents on portal hypertension and on the complications of cirrhosis are worth reading in full, and both prognostic calculators are freely available online. Thanks for your attention.